And I'd like to introduce the next person, which is Dr. Mallis, who is with our Department of Psychiatry. And he is going to talk with you about how the epidemic has influenced both the psychosocial and psychiatric needs of patients.
Thank you, Dr. Simon. And it's a great pleasure to be back presenting with the group. I presented, I believe, 5 or 6 years ago, and let me get this connected here. And it's great to be back presenting on a very important topic. As we're all aware, we are going through a pandemic, and that has brought unique challenges to our youth and families, including our youth with cystic fibrosis. My background, I'm a pediatric consultation psychiatrist, also a board certified pediatrician, and I'm the director of our consult psychiatry service, as well as the service chief for child psychiatry at Michigan Medicine. And so in the spirit of both the foundation's meeting today and also the fact that this month is Mental Health Awareness Month, we will be talking about the impacts of COVID on mental health and focusing on opportunities for wellness and to improve mental health for our youth with cystic fibrosis. I don't have any conflicts of interest to disclose. And to start us off, I always think it's helpful to make what we discuss more real, more tangible, and there's no way better to do that than to share a narrative. So I'm going to tell you a story about a young man by the name of George. George is a 15-year-old boy, adolescent male with learning difficulties, and he also has cystic fibrosis, and he's starting to exhibit emerging symptoms of depression and anxiety as we're going through the pandemic. His parents are in custodial services at a local high school and also an EMS provider in the community, emergency services. And like a lot of families, regardless of what state people are in, there's been a lot of suffering and challenges and distress during this pandemic. So taking a step back and looking at just the baseline mental health risk for George, given that he has a diagnosis of cystic fibrosis, we know that individuals with cystic fibrosis have a 2 to 3 times higher risk of depression and anxiety through adolescence into young adulthood. The graphics on the right-hand side are actually from a well-known study called the TIDE study, where we see a significant proportion of youth with cystic fibrosis exhibiting chronic depressive symptoms and anxiety, where up to 1 in 5 youth may have a clinically diagnosed depressive disorder anxiety. The effects are bidirectional, meaning that worsening CF disease makes depression and anxiety worse, and worsening depression and anxiety makes cystic fibrosis worse. It's not just the mental illness causing treatment non-adherence. There's actually studies that demonstrate that mental illness affects inflammatory cascades, affects our immune system, such that we're at a higher propensity for inflammation in the airways and difficulty clearing mucus in individuals with cystic fibrosis. So there's a physiologic component to this. And we also see the effects on family are great, where mothers and fathers, caregivers have a much higher risk of depression and anxiety as well. The impaired physiologic function and the association with depression and anxiety is great, where we see higher risk of depression and anxiety based on lung function, body mass index, treatment adherence, as well as see the downstream effects on health-related quality of life, hospitalization patterns, length of stay in the hospital, as well as more significant risks to health. Cost and utilization is also associated, and depression and anxiety can have wide-ranging and systemic effects like it does for George and his family. And this is why there are several bodies, many of whom you know, including the Cystic Fibrosis Foundation, that have harped on the importance of mental health and specifically depression and anxiety screening, evaluation, and management as part of routine care for cystic fibrosis. And actually, there's a consensus statement that was developed in the past few years that advocates for routine screening for depression and anxiety in youth with cystic fibrosis. And many families have gone through the experience where questions about mental health and wellness have been a part of the routine assessment for their child. So we go through the story of George and his family. We see during the pandemic, on top of that baseline risk we discussed, there's a lack of social connectedness. George doesn't see his friends. He's not able to see family. And so he's chronically cooped up in his home and struggling with that social isolation. His only channel to access social interactions is through social media. And social media can be a powerful tool to connect with people, but it also can be challenging, especially with bullying and the fact that image on social media could be a significant factor. So George doesn't like how he looks. He has low self-worth, and the fact that he is constantly having to use social media has become a stressor for him and a challenge as he's trying to manage the pandemic. The family is going through a lot of familial distress. Both parents work as frontline individuals who may have some risk of exposure to contagion related to the pandemic. And that stress is hard to avoid. One of the analogies I heard from a colleague is that youth are kind of like the fourth leg of a table. And so everything on that table kind of slides down to the end for youth. And so when a family's struggling, the youth feel it the most. There's a lot of uncertainty for the family and for George, who's just trying to be an adolescent, trying to get through a variety of demands that are typical for his developmental stage, but struggling because of these factors. There's reduced access to resources, academic challenges with distance-based learning, and also accessing physical health needs and being fearful at times about what it means to access those needs. And for an individual with cystic fibrosis, especially early on in the pandemic, there were a lot of uncertainties and fears about that and how the pandemic and different ways that the health system was adapting would affect youth and families affected by cystic fibrosis. So like most families, George's family started to notice the signs and symptoms of depression and anxiety, and so they went to access outpatient care. And as we know, there are several challenges that we face with accessing mental health care. First and foremost, there's a lack of child psychiatrists. And a lot of child psychiatrists tend to cluster on the East and West Coast and in urban areas. And so there was delays in accessing care because of that. There are also limited specialty services where mental health is not necessarily always integrated. Although here at Michigan Medicine, there is a psychologist embedded in our pediatric CF program, and we do our best to integrate mental health care, but that doesn't always exist. And for George's family, they couldn't find that type of integrated care. And there can be other challenges to care, like busy schedules, concerns early on in the pandemic about infection risk. And so there's a lot of access issues where sometimes delays in care can occur. So it's really important for families like George's to really try to work with their primary care provider, their pulmonologist, to identify ways to mitigate those barriers and to access care. Oftentimes, starting off with meeting with a social worker or even with a psychologist, and then identifying a primary care provider that is comfortable with managing mental health care, or eventually accessing psychiatric care. And at times, psychiatric care can take up to 3 to 6 months to access, so it is a big challenge. This is a graphic that represents where our child psychiatrists are. Red essentially means bad, and green means good. And we see that green is really only present in one spot, and the rest of the state either has a severe shortage or actually has no child psychiatrists, a good chunk of the state. And so even though there's sufficient child psychiatrists in just one county in Southeast Michigan, the majority of individuals are actually coming to that county to access psychiatric care. So you can see there's a significant bottleneck in our mental health system in accessing ambulatory care. And so for a patient like George that really needs to be seen fairly quickly, this can be a particular challenge. And in his case, his depression and anxiety continues to progress. And so he doesn't necessarily need emergency services. He's not necessarily suicidal, but he is struggling quite a bit, and the traditional outpatient services are not enough. And so George is trying to seek intermediate services, things like partial hospitalization, day programs, intensive outpatient programming. But unfortunately, in the state of Michigan, there are very, very few of these programs, and most of those programs don't meet the needs of specialty populations, youth with chronic health issues, developmental needs, learning difficulties, and may have limited access to other things like substance use services or autism services. And so it can be a very significant challenge to access these intermediate services that allow youth to stay at home, stay in the community, but receive a higher level of care. And so George and his family are not able to access that. They're doing their best with the outpatient services they have, but things unfortunately continue to progress. And so what we see is a crisis currently during the pandemic in needing emergency and crisis services. Since 2006, even before the pandemic, we've had a twofold increase in child psychiatric emergencies. But the pandemic itself has actually resulted in not only a rise in emergency psychiatric care services, but also an increase in the proportion of youth that are seeking mental health services in medical settings. We've seen a 20% increase in psychiatric consultation in our own medical hospital, where youth who are being seen for medical factors are being seen much more frequently for comorbid mental health issues. And the lengths of stay, both in the emergency room and medical floors for youth with comorbid mental health concerns, is rising. So as things progress, and this is a narrative just to highlight how this may be for some families. Obviously, some families do well, but there are challenges in our system, and we need to talk about them. As things progress and George seeks emergency mental health services, it's clear that now he's starting to exhibit suicidal thoughts. He's very overwhelmed. He's struggling with his depression. His anxiety is very high. And he's also noticing his CF is challenged. He's having more CF exacerbations. And the concern is that he may need hospitalization, psychiatric hospitalization in some way to support his care. And so these are headlines that are unfortunately not unfamiliar, where there's just a complete lack of access to inpatient mental health services. And we see that there's 331 inpatient child psychiatric beds in the state of Michigan. That's been a 60% decrease from 1993, despite a twofold increase in our ER visits. Wait times can essentially make inpatient psychiatric care inaccessible. And there are times in the state where there are no child psychiatric beds, let alone beds that can accommodate infectious risk, medical comorbidity needs, developmental needs, behavioral, significant behavioral distress. And on our particular unit, we've actually seen a 10% rise in the length of stay, meaning that youth are staying on our unit much longer than they typically would. And the occupancy is 93%, which essentially means our inpatient psychiatry unit is full almost continuously during the pandemic. So we share all this, and it's not to be gloomy. It's essentially to really embrace the fact that we have a lot of challenges in our system, that we are working hard to address them. And the fact that I'm here speaking is a testament, I think, to the CF Foundation and the group really finding mental health to be a priority for youth with cystic fibrosis and for youth in general. We have opportunities that have been unlocked by the pandemic in terms of telehealth. We talked about that earlier in Dr. Simon and Dr. Nasser's presentation, that there's a lot of opportunities to engage, whether it's transitionary care or receiving mental health care or incorporating other necessary services through virtual means. Early recognition, we talked about consensus guidelines. Our clinics here are starting to screen for anxiety and depression. Actually, they've been screening for a bit of time. And that recognition can allow Dr. Nasser, Dr. Lewis, and all the other doctors that are listening here to reach out to folks like me to talk about cases together, situations together, and figure out how we can partner to address mental health needs. We want to focus on care that's customizable and adaptable. So we're working very closely to think about that, and actually thinking about intermediate levels of care like partial hospitalization, and thinking about how to integrate our care. We have a robust consult service, emergency psychiatry service, and a psychiatric hospital that's actually embedded in our medical hospital to allow us to see some youth that have significant medical needs. And it's these types of innovations that we really need to be thinking about while we standardize our care and ensure we deliver high quality evidence-based care. And with that, I will stop my share here, and hopefully I can address some questions at the end of the session today. Thank you.